Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to the OBGYN podcast. This is a monthly checkup for August, and I'm thrilled to be joined again by Dr. Sarah Kim. Welcome back, Sarah, and thanks for being here.
Thanks for having me. I'm glad to be back.
So before we start today, we were supposed to have Dr. Ballas with us as well, but as the listeners should probably remember that he lives and works in Houston, Texas, and so you can imagine what his life has been like in the past week. Luckily, I can report his home and his family are safe, but his hospital was evacuated, and he and his wife have not only been dealing with that, but also volunteering all week at emergency shelters. They also wanted to do more, so they set up a fund to give back to the people of Houston, get them back on their feet, and so far they have reached their initial goal of raising $10,000 for the American Red Cross, and now, since that's not enough for them, they've started to fundraise for the Baton Rouge Emergency Aid Coalition, which right now is actually trying to get as many packing places as they can for the displaced babies to sleep in. So what I'm asking you, dear listeners, is if you haven't already given something or donated, please consider chipping in to support them. You can find them at breac225.org or on Facebook, and I'm going to put links for both of those in the show notes, so I hope that some of you can join myself and some others and chip in and help out some babies that have no place to sleep. All right, so with that out of the way, let's get started with the monthly checkup for August. The first topic is from NPR. It is a story about a jury settlement in a trial against Johnson & Johnson for baby powder, and it's linked to ovarian cancer. This is an interesting one to me. I chose it because it hits on really a few important topics, I think medically and ethically. The first one is the link between baby powder, or talc really is what we're talking about, and ovarian cancer. And starting in the 1980s by this guy, Dr. Kramer, there were a series of papers, in more sense, that have made a correlation between the use of baby powder and ovarian cancer. Importantly, there really have not been many causative links. It's really all correlation. And that's something that we see so much in epidemiologic studies is this causation, or correlation does not equal causation. And I find that, first of all, it's interesting to me that this kind of science topic is making its way into the public life, because this jury awarded this woman $400 million for ovarian cancer, all based on essentially correlating evidence. So the first thing here is just this correlation causation. I don't know if you have any thoughts on that, Dr. Kim.
Yeah, I mean, looking at the article, I definitely thought it was, one, interesting in the sense that, baby powder is something that we use, like, it's very common. Like, it's like available on the shelf, over the counter, and people use it all the time. And I was a little surprised to definitely see that there's definitely no, like, randomized control trials or anything like that to show that the baby powder is the causative agent of causing ovarian cancer. And to be honest, I don't really know if there'll ever really be a randomized control trial in that sense. And with ovarian cancer in general, it's hard to, I think, know what really truly causes it, because I think there's like a lot of effects. So to say that this particular patient who had ovarian cancer, it was due to or attributed to baby powder in general, I was very surprised that based on the fact that it's just the patient just happened to have that exposure, and to say that was actually potentially the causative agent of ovarian cancer, and that it was in that actually won the case was very surprising. Something that I don't think overall we see commonly, I think. So I just thought that I see why just because the research does go back to the 80s as to why this may have been potentially something that the patient kind of said was the causative agent of ovarian cancer. I thought it was interesting definitely to see that even though there's no actual evidence that that's the causative agent, that the patient had won the case.
Yeah, I mean, I think that's exactly the root of this. Is this woman had ovarian cancer, very sad. We know there are probably at least several, if not multiple, etiologies of it. And I'm not even to say that talcum powder does not cause ovarian cancer, but how do you know you caused ovarian cancer in this woman? So that was difficult for me. And if we have a hard time with that, I can only imagine what a lay, public jury, is trying to make sense of when they're going through a trial like that, which I want to come back to in a second. The second thing that I thought was interesting out of this is this guy, Dr. Kramer. Like I said, he was an author on these early studies. And he's also now a paid consultant on many of these cases. And apparently there are hundreds of these cases against Johnson & Johnson, and he gets paid to be a witness at these things. And that just raised a lot of ethical concerns for me. He's out there and he's quoted in this article saying that he is, basically 100% sure that talc powder caused ovarian cancer, which I don't know how he's that sure. But of course that works for him because he's getting paid essentially to say that.
Right. Yeah, I definitely saw that he definitely has personal bias and personal gains as someone who's definitely a proponent of the idea that this causes ovarian cancer, and I think that his studies show that. And at the end of the day, it's very like equivocal data. I don't think it's anything that 100% showed that talc powder was something that actually caused ovarian cancer. But I thought it was very, there were definitely ethical issues, and a lot of other people who are quoted in the article say, most of the data is not conclusive, and it's a little bit, there's nothing to say that it's not the causative agent. However, there's also nothing to say that it's actually the causative agent. And, one of the professors of public health say, like, it's not proof positive. Like, they're suggestive, they support idea, but I would never tell anyone that, like, oh, this is the real reason why you had ovarian cancer. And, I think Dr. Kramer potentially has some personal gains from, actually being this paid consultant and kind of staying trial and having done research in the field. I think he might have some personal gains from, saying that potentially this powder talc is a causative agent of ovarian cancer.
Yeah. Just to, because I actually went through this, and maybe we'll cover this in a future ovarian cancer series, but the way that the talc is supposed to cause cancer is that women put it in their underwear, it gets up through the vaginal tract into the uterus and then to the fallopian tubes and ovaries. And apparently there are some studies where they found talc in ovaries, and then there's some evidence that it does cause inflammation. So it's certainly plausible that it causes ovarian cancer. But I want to read from actually one of Dr. Kramer's papers. This is, I think, from 1992. This was the conclusion of one of his papers. It said, these data support the concept that a lifetime pattern of perineal talc use may increase the risk for epithelial ovarian cancer, but is unlikely to be the etiology for the majority of epithelial ovarian cancers. So even he says, sure, this might cause it, and he thinks that it causes some, but not all and not the majority. And yet, he was up there on the stand saying that this woman's use of baby powder caused her to have ovarian cancer. It really concerns me.
Right, and I think what also makes me concerned is that, like, this is what messages is sending out to people, to the general population about baby powder use and talc use. That I think, at least for us, like, we go back and read the potential, like, New York Case read article and saw also that he was inconclusive about it. But just reading the article itself, for the general population, they in their mind were like, oh, well, this patient won this case. Definitely talc powder is going to be the causative agent of ovarian cancer. And who knows? I feel like they might start suing Johnson & Johnson more for whatever happened. And actually, the paper says, like, the article says, like, this wasn't the first jury award against the company for talc use. So that just goes to show that in the past, this obviously was also something that was brought up.
Yeah, I think that brings up my last point I want to make with this article, and this is a little off topic, but it is, how do we go about adjudicating cases like this? and this goes into malpractice for us, but this is also sort of a malpractice-ish case with Johnson & Johnson, is how do you take people who have no medical training, no science training, and then you expect them to understand the nuance of something like this or something like one of our cases, and think they get to a fair answer? I mean, it would be like you and me being asked to be the jury on some complex business case, where there's all, like maybe during the financial crisis with all these different instruments that they were using. I don't know enough about that to make a really good decision, and yet we're taking these people who are mechanics or teachers or maybe even lawyers and saying, here's all this complex medical stuff, now come to their decision. Right.
Because at the end of the day, they may not necessarily even like understand, like I said, the pathophysiology and the etiology of these things. And obviously we're not there at trial, but I think depends on how this information is presented in a way that even if you kind of lay it low or I guess try to explain it to the layperson, it's something's a little bit hard and even to kind of understand, grasp their mind around. So it could, for the general population, it's much easier to understand it as well. This patient was exposed to A and then had eventually resulted in B, so A must equal B. I think that's a lot easier to grasp their mind around than to say like, oh, this is a multifactorial disease, and other studies have shown that it's something that has other etiologies and pathophysiology. Those are things I think to the general population it's kind of hard to grasp their mind around.
Yeah, I mean even for us, I would say in other areas, I mean, look at politics right now. People like A or B or yes or no sort of answers. When you start getting into nuance, you lose people.
Right.
So I can almost see how this was presented in court, and I don't blame the jury for coming to a decision I personally think was not the right one, because how can you expect them to do that? Now there was talk, again, I told you this was off topic, but there was talk in some circles about having dedicated courts for malpractice that was run by people who are specialized in medicine, have a background, so they can say yes, this was negligence, no, this was not, or this was malpractice. That never went anywhere, but it kind of goes against the ethos of the United States. But I think that for some things it's important.
I think having like a paid consultant also kind of blurs the picture a little bit. And I think I understand why they may have a paid consultant, but I think at the end of the day, for the argument's sake of, well, this is like an expert in this field, so I understand why they want that input, but it also kind of, I think, obscures the picture a little bit, like depending on who the paid consultant is.
Agreed. In any case, so I hope that was interesting to people because I found it very thought-provoking on a few different levels. So let's put that behind us, and we're moving fast tonight. We're going to go into the next one, which is from Dr. Kim. So Dr. Kim, why don't you tell me what you brought tonight?
The article that I picked is titled History of Breastfeeding at Risk of Incident Endometriosis. It's a prospective cohort study. I actually came across a very short article, actually, in the New York Times about this, and they quoted this article saying that there is a study that was done in Boston and Brigham that basically showed that breastfeeding decreased the incidence of endometriosis. So I kind of went up and looked at the article, and basically it's a prospective cohort study that looked at the participants was actually a huge number, approximately 72,000 women, and they went back as far as 20 years and basically they asked how long they were breastfeeding, it was a questionnaire. Basically, they asked them how long they were breastfeeding, and how, what their parity was, and the outcome that they measured was self-reported laparoscopically confirmed endometriosis in concordance with the medical record. So they actually asked the patients, like, was it laparoscopically confirmed, and also went back to the EMR, basically electronic medical record, to kind of try to confirm that as well in Paris women. And what they found was that there was a direct correlation between the length of breastfeeding in lifetime breastfeeding, exclusive breastfeeding, and postpartum amenorrhea, and the incidence of endometriosis among the patients. And I thought that was interesting to see, well, one, because endometriosis is something that we as gynecologists come across, pretty frequently. And a lot of times, people do ask, like, is there any way to prevent it? Is there any way to kind of decrease my risk of it? And I thought the paper kind of, laid it out pretty in an interesting way of showing that breastfeeding, which a lot of us know, which is a recommendation, breastfeeding has been shown to have other multiple benefits. And I thought it was kind of interesting to point out that there an added benefit of potentially decreasing endometriosis in Paris women.
Yeah, I mean, this is one of those articles where you say, yeah, sure, that makes sense, right? But it doesn't mean it wasn't worth doing and worth, because a lot of times we think something makes sense and then you actually look at it and it doesn't actually work. But this one, you're thinking, okay, endometriosis is primarily fed by estrogen, so if we can reduce the estrogen exposure, we should decrease the incidence or at least the progression of it as well. We do that now with IUDs and Lupron and even birth control pills, right? So it wasn't too surprising to me that this worked, but I was actually a little bit surprised with how much it worked. At the end of the paper, they do the adjusted odds ratios for length of time, and there's like, say, 0.45, so basically 55% reduction in relative risk by breastfeeding over 18 months. That's pretty huge.
I think I actually wrote, like, one of the comments I made, I totally agree with you. I was like, well, this is a surprising result, but I think the percentage of, like, how much it does decrease it, I think was what was pretty significant in this particular paper.
Yeah, and one of the things I would like, maybe in a future study now, is actually looking at women who have endometriosis, they get pregnant and breastfeed, versus women who get pregnant and don't breastfeed, what the progression rate is.
Yeah, and that'd be very interesting, but a little bit difficult to actually measure.
Right. Yeah, that's what I was going to say, the same thing. It's such a multifactorial process that we don't really understand anyway, so it's difficult, but I mean, it kind of goes along with this study we have here is, they found their endpoint, you could argue with the endpoint, but they were consistent with it, and, breastfeeding definitely works as prevention, it was seen here. But maybe we can use it as treatment. No, I'm not saying that everyone who has endometriosis should go ahead and get pregnant so just they can breastfeed for 18 months and decrease progression, but it certainly at least shows what a profound effect estrogen has on the disease process.
Right. The one thing that I kind of was thinking about, though, a little bit is that in terms of the population that they're researching, we also know that endometriosis is a factor in fertility. So it made me think about, the people who were pregnant and were paras and delivered babies, maybe inherently, there's something inherent about them that they're not really at, like, high risk of getting endometriosis. Like, would that skew the data a little bit? I think that was, like, the only kind of question that I had.
No, that's a good point. So these women who have breastfed for more than 18 months because they had maybe 2 or 3 children, they probably are less likely to have endometriosis because they got pregnant 3 times. I can see that's definitely a confounder here. Again, that's why it would be nice if they took women who they knew had endometriosis and then followed them to see what happened, as a starting point.
Mm-hmm. Right, because I think people with, like, prior diagnosis of endometriosis was excluded from this, so because they didn't want that to be a factor. So that would be very interesting to see, like, did that affect later on?
Well, there you go. We have some research to do.
Yes.
Any other thoughts on that one?
No, I just thought it was just like I agree with you that it just kind of confirmed, some things that, like, oh, this makes sense, and I just thought it was important in terms of, again, when we, like, counsel patients that are like, oh, breastfeeding versus not, this potentially could be another plus side of, like, breastfeeding.
Yep, I mean, all we do, it seems like every year or two, we get another reason why breastfeeding is good. Actually, that's interesting. Again, we're going to go off topic just a slight bit here. I had a woman in my office on Wednesday who is breastfeeding, having a very difficult time, but she's doing it, and she wants to go to a support group because, she's having a difficult time, but she says, I don't want to go there and be judged because I hate it. And I thought, we get this sometimes in our hospital because we are baby friendly, breastfed is the best. And some of the women feel very pressured by that, almost to a negative degree. We're turning them off from it. And so I think it's so important that we do stress how good breastfeeding is and how important it is. We also have to recognize that it's maybe not for everyone.
Right. I don't want it to be like guilty thing. And I totally agree, because when I round, like postpartum round, and we usually ask them like, are you breast or bottle feeding? I would say greater than half the people who are not breastfeeding, they always start with, I know, I'm sorry, but I'm bottle feeding. And like, it's, it surprised me when I was an intern, like, why are you apologizing that you're bottle feeding? It's not, but I think it was more like they felt a little judged in a way, because everyone was like constantly asking, I guess, the nurses educate them about the benefits of breastfeeding. So some of the mothers would actually start out with like, I know, I'm sorry, but I'm not breastfeeding, I'm bottle feeding. So I think I agree that, I think they need the education of like what the benefits of breastfeeding is, but at the same time, it shouldn't be like a coercive thing.
Right. We don't mean, there's enough as being a new parent that you can feel guilty about.
Right.
Trust me, as a father of an 18-month-old, I can tell you that in the first 6 months, guilty about almost everything.
Oh.
You feel like you're not doing something right. So we don't need to add any more to that, especially to first-time new moms. But anyways, it's a fine line, between trying to promote something that we know is beneficial and, not, making it more stressful and ostracizing women for not doing it.
Right.
Anyways, a little off topic, but I thought of it for this one I saw the other day.
Yeah, I think it's relevant in terms of, because one other thing was like, I wanted to like touch base on education of patients, about breastfeeding in general. So.
Right, we can add this to our list of things to tell them.
Yes.
So the last topic we have today is from an article in AJOG. It's entitled Maternal Childbirth Experience More Than a Decade After Delivery. And what they did is they surveyed 576 women, 10 to 17 years after delivery, and they looked for their satisfaction, how much distress they recall with their delivery, and to see what effect different routes of delivery had on that even 10 to 17 years later. What they found was that women with a planned cesarean delivery, so no labor, and women with vaginal delivery scored roughly on par as far as their satisfaction with their delivery process. Women with a cesarean delivery after labor, or women with an operative delivery, vaginal delivery, had lower scores, and they were about the same. There's some differences. The other thing they found was that the older the woman was when she had that birth, the more likely she was to feel better about it. So the first thing that I really took from this, now listen, this is small number of women, 500 and some women. It's there's so much recall bias that you could play in here because it's 10 to 17 years later. There's so much time in between. But one of the things I really took away from this, and I have to remind myself, is that for a lot of women, this is a singular event in their life. Right? This is something that they're going to remember and carry on the positive or negative feelings about for maybe the rest of their life. And obviously, these women still had feelings about it. I mean, they were asked about it, so I don't know if they had spontaneous feelings, but some of them had some pretty negative feelings, even 10, 15 years after their delivery. And so I think when we are caring for women and we are talking about maybe we're going to do that cesarean delivery after they pushed for 4 hours or they didn't dilate, we have to remember what an impact that may make for that woman's future. And not just medically, but also socially and emotionally.
Right. I 100% agree. I was reading this and I was actually shocked that people actually remembered a lot of their the labor course and how they delivered and how they felt at the time. Because I think as obstetricians, because we do so many deliveries, for us, it's, another delivery, another C-section, but for that patient, it's like a singular event. And what the other part that I didn't realize, the fact that like unplanned C-sections, the ones who are in labor and a C-section has such a low score. I also wonder, is that something to do with maybe our communication as to like what's actually happening with their labor course? Is it explained to them as to why we're doing C-section, fully explained to them, or is it more of, okay, well, we're not dilating, let's just go and do the C-section? Because I think sometimes patients understanding what's going on with the labor course and what's going on with their labor may not always reflect what the obstetrician is seeing. And from anecdotally, one of my friends, she delivered like a year ago, and she was telling me like I had the worst experience ever. Like the baby pooped inside me, they didn't do a C-section. I don't understand why. I don't think it was ever explained to her like meconium is not an indication for a C-section. It's okay to watch. And she's like, I think my baby like came out looking blue because of the meconium. And I was like, well, no, babies, potentially yes, but when they're first born, they're living in shock. They might not cry. But she's like, yeah, but I don't think like my baby was good because he did not like when the baby came out, it didn't cry. And I think it's because like it had pooped inside and no one like told me I had to do a C-section. So seeing that, I realized, oh, there's obviously some kind of disconnect, and she was very dissatisfied, even though the outcome was good. Like the baby did fine. She was very dissatisfied with her care, and I wonder if this kind of article kind of reflects on a little bit that based on how their labor course is going, I wonder if that also affects like how they view like how things went.
Yeah, I totally agree with what you just said. And I'll even go a little step further. Not only is it what they know or what they understand about their labor course, it's also what they know and understand about going in before they even go into labor. Like, what is their expectation? And that's one of the things I thought. So women who had a planned C-section, they were okay. Right. But women who went into labor and then had a C-section, they were the ones who were distressed. Like this is where they used in the paper.
Mm-hmm.
And that to me says that their expectations weren't met. Right. And they thought they were going to have that in their head. They were going to have vaginal delivery, and that's not what ended up happening. So to them, that was traumatizing. Not for everyone, perhaps, but for some women, it is.
Right. And I think expectation is a huge thing because people even come for inductions, and their expectation is I'm going to deliver the baby within 12 hours. I'm like, potentially, but not necessarily. And I think that's usually when that doesn't happen to what their plan is when people are like, why is my induction course taking such a long time? No one told me it might technically be like 24 to 48 hours. So I think it goes back. Definitely, expectation is a huge factor because, like you mentioned, the people who knew that they were going to go for a C-section definitely, was on the same in terms of satisfaction and what their thought was on the same par with people who deliver vaginally.
Yeah. So I mean, you said earlier, a lot of that comes down to how we communicate with women. Tell them how long induction takes. What is the actual success rate of an induction?
That's true.
Right. So at our hospital, because I did these numbers a few years ago, if you're a nulliparous woman who comes in labor on your own, you have an 85% chance of having a vaginal delivery. If we induce that same woman at any gestation, so I'm lumping together here, but you essentially double that risk to 30% chance of a C-section. And I had those numbers because I did those numbers for the hospital, and so I use those numbers when I talk to women. We're doubling your chance for a C-section, so you have a 30% chance of walking out with a cesarean delivery.
Yeah,
so that's pretty high. Right? Mm-hmm. So I mean, it's lower than the C-section rate in some hospitals, but
right.
So that doubling risk, I think, they can understand that, and internalize that, and say, okay, there's like an almost 50-50 chance I'm walking out with a C-section.
Right.
So maybe I won't be so upset if that happens.
Right. So I mean, I agree. Like I think those numbers kind of give a better sense and say like, oh, you may potentially end up with a section. So I think I'll be using that. I didn't realize that was a rate. So I think it'll help with like counseling and setting up expectations.
Yeah. So the other thing that I found, that the last part of that expectation, or not expectation, but was women who had a second vaginal delivery remembered the first delivery better. Right, as opposed to when only had one delivery, which anyone who delivers babies probably is not too surprised by that because the second delivery is usually a little easier, right, a little faster.
Yeah.
And so, but it's interesting. The human brain and human memories are so elastic, and what we think we remember is like a version of what we remember, right?
Right.
Of the actual events. But so having a second delivery makes the first one better, which was by the way not the same for C-sections. C-sections was the same. Didn't matter if you had 1 or 2 or 3.
Right.
But vaginal deliveries, which I thought was interesting.
Yeah. It definitely is, because a lot of people, even in our hospital, come in, and when you ask them, like, oh, what were your other 2 deliveries before? Most of the time they talk about their first one and say, like, oh, my first one's horrible, or like, my first one's great. And they usually do remember. Actually, I'm always surprised at how well they remember, if they do remember what happened in their course. Even though it might not necessarily be like medically accurate, they might not know exactly medically speaking what happened, but they definitely remember like how they felt, the interaction they had with the nurses and the doctor. So it is actually interesting to see like how they remember like the first delivery and then subsequent ones, and how that also could impact how they remember the like, subsequent deliveries, I think.
Absolutely. So yeah, it's obviously very, again, not the biggest, best study, but at least highlighting a couple points to me that I can take home, which is, and again, this is something, because you said we do this all the time. This is our job. We deliver many babies per week for most of us. And so we have to remember that for each woman, that's their one delivery. Right. And so we do the best we can to make that the best experience for that woman, especially concerned with what she wants.
Right.
And then just doing our best to make it a pleasant experience all around, because she's going to carry that memory with her for maybe ever.
Right. Agreed.
All right. Well, that was our 3 topics for today: the ovarian cancer and talc, breastfeeding, endometriosis, and the childbirth experience. All 3 of those links will be in the show notes for those who want to go through and find a little more. Please consider giving to the Baton Rouge Emergency Aid Coalition. Help out our friends and our colleagues down in Houston. And thank you, Dr. Kim, for joining me yet again on this monthly checkup.
Always a pleasure.
Next week, we should be back again with a journal club for September. So until then, thank you all for listening. Bye-bye.